Hi everyone, good evening. This is Batul, the moderator for today's session from IJCP, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our distinguished speaker who is here with us. Well, sir needs no introduction, but yet it's our great pleasure and honor to introduce him. He is none other than the very renowned critical care expert, Dr. Prashant Nasa, sir. Sir is MD in Anesthesiology, FNB, CCM, ETIC, Senior Clinical Fellow Integrated Critical Care Unit, New Cross Hospital, Royal Wolverhampton Hospital, NHS Trust, UK. With such wonderful insights, we are going to talk about the topic for today, which is Mastering Fluid Stewardship, the Art and Science of Flow Therapy. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So over to you.
Thank you, Batul. It was a privilege to be part of the group, and thank you for having me here. Let's start with the fluid stewardship. I think I will be talking on how we can start a fluid stewardship, and for the four most important, I think we should understand why we need a fluid stewardship. And this is because we published this book this year, and I think this has become a very popular book since we have published early this year. It's already been downloaded by nearly 1 million people across the globe. This also tells us that there is a need of a knowledge on rational use of IV fluids, but also this could be just because this was an open access book, so people love to buy freebies. So this could be something like that. Let's see. I will be sharing a link for the book, so stay till the end, and you will also able to download this book, which is a very wonderful resource which you can use at the bedside. So, what is fluid stewardship? We have used this word so many times into our medical practices. Most common example of that is antimicrobial stewardship, where we try to rationalize the use of antimicrobials. So, very similar to that, I think there is a need for coordinated interventions to select the right fluid at dose, duration, and the type of the fluid that will result in the best clinical outcomes and prevent the adverse events related to the use of the fluids. So we'll be seeing why we need to do that and why that's part of our daily practice, whether you are working in an intensive care unit or you're working in a ward setting or you're working in an A&E setting. So it's really important to use the fluid very judiciously, and that's what fluid stewardship talk about. Let's start with a hypothetical case, and this could be a good case to build up why we need to think of IV fluids as like a drugs. So this elderly gentleman with COPD and diabetes was operated for a bowel surgery, and post laparotomy he was kept nil by mouth for next 3 days to look for the stoma to heal up and the anastomosis to start working, the bowel start working. So patient was febrile, there is no significant drain, patient stays hemodynamically stable, and these are some of his lab values. Do you think we should start IV fluid for this patient? Uh, I think most of you will agree with me that we will be starting an IV fluid for this patient, and that tells us that yes, most of these patients who are not able to take orally, so sometime we need to give some sort of a fluid for them, and that could be a maintenance fluid in this case. So we need to start an IV fluid. But what type of IV fluid will you be using? Whether this will be a saline bag, it could be a balanced solution like a sterophondane or a plasmalite, or for that matter, a simple Hartmann or a ringer lactate. It could be a dextrose saline bag, or it could be an albumin. So, what sort of fluid which you would you prescribe for this patient? And that's a common dilemma we almost always have for our patients, whether we are treating them into ward or any other setting. So this patient, after 2-3 days, you will start seeing that the patient has become started bloating up, his renal functions have deranged. We think that this is all happening because of the sepsis or because of the disease which he had. He had an obstruction, we did laparotomy, and now by third, fourth day, the patient looks more swollen. What is all happening very similar, very simply put forward, is fluid accumulation. So fluid is getting accumulated into the whole body, and we try to blame this probably because of the disease. Yes, that's one of the most possible reason that the patient is developing this so-called fluid accumulation because of the disease pathophysiology itself, where we have these leaky capillaries. But are we doing some harm by using more and more IV fluids? The answer is yes. We are also contributing to that fluid accumulation by giving unjudicious use of IV fluid, and then We think this is part of our patient, but not just everything by the patient disease itself, but part also because of the way we use the fluid in this patient. The art of fluid is very very old, and this is more than now 120 years old, somewhere back in 1838, when Thomas Latta first described the use of IV fluid for resuscitation in an Indian cholera patient, while that spread from Indian subcontinent to into European subcontinent or European continent. And then IV fluid for the first time was used intravenously, where they see the response of IV fluid for the treatment of a cholera actually led to saving lives. And that what was a dramatic change, the way we started treating up patients with dehydration, at least for patients who had a cholera which have lost a lot amount of IV fluids because of their watery stools. But then, how we think that we are masters, like this gentleman who can do the shooting and win a medal in an Olympics. But that's not true. We know we are not trained enough for the use of IV fluids, and to tell you that it's not just few of us who are not trained, but almost everyone. And most surgeons and anesthetics hardly care about perioperative fluid accumulation syndrome. So that patient which we saw, most of the time, we that picture which I showed you with a larger tummy with a lot of fluid accumulation is is a common picture while you are treating patients in your intensive care units or into wards. So by third or fourth day, you will see many of these patients unnecessarily getting fluid accumulated, and most of the time, it's also because of the way we have used IV fluid for these patients, considering the choice, the amount, and the type of the fluid which we have used for these patients. And to tell you, we actually tested this through a global survey, which was done a few years back as part of International Fluid Academy. And we checked the knowledge and the awareness about intravenous fluid use across the globe. We had these more than 1,000 participants from more than 97 countries, and what we found was the average the passing percentage was of course 50%, while average score which we could receive by these 1,000 odd respondents was only 46%. So that tells you that if most of us are uh, going with this particular knowledge assessment exam again, many of us would fail. So that tells us that the awareness, the knowledge about IV fluid is still inadequate, and that is the reason that led us to think of getting a proper comprehensive handbook and to talk about the message of fluid stewardship. So when we asked, the people in this group, in this particular survey, what do you think the choice of maintenance fluid is? So this was a wheel which we received. The responses were very haywire. People were using different things for maintenance fluid in these patients who have been kept nil by mouth because of either surgery or some other reason. And this is the different type of fluids which were found. Of course, there was a single choice question, and that would lead to almost 80% of the people could not passing that particular question. So what is fluid accumulation? To simply put forward, I think you must have seen this ad of Michelin tires where a person is all swollen up, though it has been shown something powerful, but unfortunately our patient do not behave like that. And whenever there is a problem of a fluid accumulation, that leads to almost every organ of the body get part of that fluid accumulation. It affects head to toe, from your brain, from your heart, kidney, lungs, even thoracoabdominal wall to your brain. So fluid accumulation is not simple thing. It's not just a cosmetic thing. It does not simply put forward the swelling of the body, but it produces a problem which can affect the brain by causing increase in cerebral edema, and it affects the heart, it affects the brain, it affects the lungs and renal. And in a critically ill patient, it also worsen the outcome. I will be showing that result also with a very large meta-analysis which was published on that. And how much time we spend in the medical school learning about IV fluid? Unfortunately for me, this was only 0 hours. So I never was taught anything about IV fluid other than saline bag and a ringer lactate. But how to use them judiciously was never talked about in most of our medical school. I don't think this has changed even now. So we know that there is so much talk about early treatment, and there is always a concept of golden hour. This applies very truly for patients with thrombolysis, patients with who needs thrombolysis for acute coronary syndrome or who needs thrombolysis for a stroke. There is also a talk about IV fluid resuscitation in patient with septic shock, that there is a golden hour. As soon as you make a diagnosis of a septic shock, you tend to give them IV fluids, and IV fluid resuscitation is an important part. So there is a lot of progress which has been done, that we should try to identify these patients with septic shock early, the way we are identifying patients with acute coronary syndrome or patients with stroke. And we should tend to treat them with IV fluids, with antibiotics early. And that's the usual scenario which we see in the intensive care unit. Whenever we see an hypotension, we give a fluid bolus. Whenever we see a patient with tachycardia, unexplained tachycardia, or oliguria, or high lactate, or worsening metabolic acidosis, our first response is to give a fluid bolus. If we see patient is not responding, we give another fluid bolus. And what is all happening is that gentleman with swollen abdomen by third or fourth day. So we understand these, very clearly, that patient who is hypovolemic, patient who is sepsis, need resuscitation to maintain the organ perfusion. But what is equally important is a patient who develops hypervolemia because of injudicious use of fluid will also develop a problem, something known as fluid accumulation, which will affect the whole body, which will also worsen the problem. So we need to attain that balance, a delicate balance of treating hypovolemia, but not reaching up to a situation of hypervolemia or a fluid overload, or simply put forward, fluid accumulation syndrome. So yes, we need to treat the patients early who needs fluid, but we need to stop whenever it is not required. And that tells us that our whole principle of medicine is first do no harm. And I think that also applies for intravenous fluid use into our patients. So that put forward a real reason that why we should think that IV fluids are drugs. They should be used as like any other drug. We should have a proper dose, duration, and a de-escalation plan whenever we use IV fluid as a drugs or IV fluid as for treatment of any of the patients into any of our settings. And how to set up this? So if we understand that IV fluids are drugs, we need to use them in appropriate dose, duration, de-escalation, and of course the different choices we have as an intravenous fluid. So that will be what type of drug we need to use. So let's look at the first part. What is the type of the fluid we should be talking about? There is always an ongoing debate. We know the starches are no longer available into our armamentarium. The only thing we have is a saline bag versus a balanced solution, like a so-called commercially available balanced solutions like a sterophundane or a plasmalide, or they could be other conventional old balanced solutions like a Hartmann solution or a Ringer lactate. But do you remember how much sodium is there in a liter of a saline bag? This is equivalent to 17 bags of chips, 17 bag of large chips, which is their amount of salt in 1 liter of saline. So just imagine, if you're giving without thinking a liter of saline bag, you are actually giving amount of salt which is equivalent to a 17 bags of chips. So this much amount of sodium is there in a bag of, or in a liter of a saline, which is a 0.9% saline bag. So normal saline is definitely not normal. It's abnormal. It can cause dose-dependent hyperchloremic metabolic acidosis. It increases the risk of acute kidney injury. And there is some evidence that it increases the risk of mortality, at least in patients with sepsis and septic shock, where we use large amount of fluids. And the reason why we say this so-called saline bag as a normal saline is also founded on a very, very weak reason, which was proven that there is so-called word normal is abnormally attached to this one. So we should stop using the word normal saline anymore. I think it's an abnormal saline. We don't use normal anyway for any other thing. We don't use normal for a normal blood or a normal for normal albumin. So why we should be saying that saline is normal when there is enough evidence that it's abnormal, and that's why we should think of saline bag as any other drug. And there is very a definitive evidence that it increases the risk of harm if it is used injudiciously in our patients. And that what recent guidelines also propose, that for resuscitation of most of the patients into intensive care settings, we should tend to use balanced crystalloid as compared to a saline bag. And this applies to most of the intensive care patients we have, whether they are patients with sepsis, whether they are patients with acute kidney injury, except patients with head injury, or especially patient with severe head injury, where we are considering a raised intracranial pressure. Other than that subset of population, most of the intensive care patients, if they require resuscitation, it should be a balanced crystalloid. What is a balanced crystalloid? Something which has a balanced electrolyte solution, which does not cause acidemia as typically happens with a saline bag. And in a setting like in India, so we recently proposed this as part of the guideline which came from Indian Society of Critical Care Medicine, which I was fortunate to be part of. So we recommended in an Indian setting. This does not mean, or in a resource limited setting, it does not mean always that we should tend to use a sterophundin or plasmalite, which of course is a cost addition or a cost constraint at certain places, and then availability could be an issue. So in those situations, a ringer lactate or a Hartmann solution, which is a balanced solution, could be a replacement. So if you are resuscitating any patient with sepsis and septic shock, think of a balanced solution first. And if you don't have those so-called newer type of balanced solution, even a ringer lactate or a Hartmann solution is good enough to resuscitate these patients. But please definitely avoid a saline bag for resuscitation of the patients who are requiring some sort of hemodynamic stabilization by using your IV fluids. Talking about maintenance fluid, we saw the first case where we discussed about a patient who is otherwise hemodynamically stabilized but needs some sort of replacement for unable to take a oral. So somebody who is not able to take a oral fluid just because we have kept an nil by mouth. So that sort of maintenance fluid is known as a maintenance. While there could be other name like a replacement fluid, if the same patient would have been losing a lot amount of drains, that becomes, so the fluid which will you use for that patient will become a replacement fluid. So a mild difference, but the thing is, when you say consider an IV fluid used for a replacement, then you should think what you are replacing for. If you are replacing for a blood, then of course the best maintenance fluid would be something like a blood. So if patient is losing but still hemodynamically stable, then the first thing should come in your mind is try to replace that blood, control that bleeding. But if patient is having a lot of drains, a patient has a nasogastric tube and losing a lot of amount of gastric secretions are full up of acid fluids. So then our saline bag would be a better replacement fluid, which is a replacement fluid for that case. So you are replacing whatever you are losing. While in a maintenance fluid, patient is not losing anything. It's only that patient is not able to take from the mouth, and that what is maintenance fluid. So what we usually do, what we usually take in a day is something you need to replace through an IV fluid, and that becomes a maintenance fluid. So what we usually do in a day setting, or for most of the humans, we need at least 1 ml per kilogram per hour of water, and that constitutes our water requirement. Then there is a glucose requirement of 1 to 1.5 gram per kilogram per day, a sodium requirement almost 1 to 1.5, and a potassium. So simply put forward, nearly you need 1 of water, 1 of glucose, 1 of sodium, and 1 of potassium. And to tell you, unfortunately, there is no commercially available fluid which is fitting into this criteria. So you cannot have an ideal maintenance fluid looking up to this. And that's the reason, if you have seen the first question, what type of maintenance fluid you would be using for that patient, unfortunately, none of them, because none of them have enough water to have in the same proportion of sodium. So if you are going behind the water, what will you give is a lot of sodium, and that would what we usually do. So using a saline bag or a ringer lactate as a maintenance, what we add is a more of lot of sodium which we add to these patients. And why this is important? Because this study which was done in Belgium by Professor Egan Mortel, they actually looked at healthy volunteers. So to tell you, this was not a study which they looked at in the patient, but the healthy young volunteers between age of 18 to 25. So these were very healthy volunteers, did not have any disease. What they gave them was an isotonic fluid, which was like our dextrose normal saline or a dextrose saline along with potassium. And then they gave them the other, after a few days, they gave them an hypertonic fluid. So same 12 volunteers were given first an isotonic fluid, which is equivalent to dextrose saline plus potassium. And after a few days, they given them a hypertonic fluid, which was a 5% dextrose, 1/4 of a saline, which is of 0.9%, so nearly 1/3 of that sodium concentration, and then potassium along with it. What they found was patients who were given isotonic fluid, which was a dextrose saline, tend to have a lower urine output and tend to have a higher fluid retention in the body as compared to the patients who were given hypotonic fluids. What does that mean? A patient who has been given unnecessary isotonic fluid tend to retain that water in the body, and because of that they have also a lower urine output. So our kidneys are very very poor to handle extra sodium. So if you give a lot amount of sodium, it will not that kidneys will throw out that sodium, it will tend to retain, and that retaining of sodium will also retain the water, and the patient will start swelling up. So if this was happening in a patient or in a healthy volunteers, imagine this would be definitely happening in a critically ill patient or a patient who needs otherwise into a situation where 10 kidneys are not working appropriately. So that's the thing which applies very similarly. If you have gone to, if you drink, if you don't drink, then that's perfectly okay, but that explains why the salt or a peanuts or the salty snacks are given in a bar. Because when you are giving these salty nuts, what will happen is you tend to pee less, because that salt will retain the effect, the cause the kidney to pee less, and then you drink more because you are thirsty. So it's a win-win situation for a bar owner. By giving you free complimentary snacks, what it tells you is he or she is actually making you to drink more, and that what is a good reason to find complimentary snacks why available in most of these settings. So remember this, particular picture again, that we are contributing to this pathophysiology. It's not the patient disease itself. By injudicious use of our IV fluid, we are adding to this problem. So this fluid retention is happening not just because of the patient disease, but also because the way we use intravenous fluid for these patients. Now come the dose. So again, what dose? I think the guidelines here differ. The guidelines, at least for resuscitation, says still 30 ml per kg, though this has been debated very often, and most probably in the next iteration they will come up with a smaller amount. What we do it in a bedside practice, and I think that has also been given now into most of the review articles, tend to use a smaller amount of fluid. Look the response of that fluid resuscitation. So rather than using 30 ml per kg and then look at the response, you use a 4 ml per kg, like a half liter bag or a 500 ml bag, and then look at the response of that, whether patient is, you are able to increase the blood pressure, you are able to improve the targets. If you are using a hemodynamic tool, which you should be using, then whether you are able to look out the fluid responsiveness again, and then are you able to increase the urine output or other macro perfusion targets which we are targeting to. So looking at that, instead of using a smaller, larger fluid bolus, always tend to use a smaller fluid bolus and look at the response of that fluid bolus, and what is the minimum amount of fluid bolus which you need to do to look for fluid responsiveness is 4 ml per kg. So if you are giving a 500 ml bag, you are able to judge what is happening to the patient, and if patient needs more, definitely you can adjust and give it more, rather than giving 30 ml per kg and then thinking that yes, whether the patient is good enough resuscitated or not. So fluid responsiveness does not mean that you need IV fluids. It only tells you that patient is having a fluid responsiveness. It's still on the steep portion of the curve. And anything which will you continue a fluid positive balance by third day will add to the mortality, and this large meta-analysis I was talking earlier will will lead to a worse outcome into these patients. So we have to remember that fluid responsiveness should always be considered along with fluid tolerant. If patient is not fluid tolerant, fluid responsiveness does not have any value. So if patient requires fluid, which is decided by your macro targets, you should consider a fluid responsiveness. If patient has fluid responsiveness, still it doesn't tell you that I should give fluid. If patient is not fluid tolerant, he is leaking fluid into pulmonary capillaries or in the systemic capillaries, then you should be very, very careful of giving extra fluid to these patients, because that will lead to definitely a harm. And that what has been proposed into septic patients by our recent article, how to use judiciously IV fluids in these patients. Now coming to the last part of it, what is duration and de-escalation? I think that should be daily. I recommend this to be more than daily, but yes, at least daily you should look at the need of IV fluids. Why we need an IV fluid? Can patient take orally? As I said, there is no best maintenance fluid, and the best maintenance fluid is patient is able to take the oral food. So as soon as patient is able to take the oral, please de-escalate, please stop everything whichever going through an IV fluid or going through an intravenous cannulation. So reassess the need of IV fluid daily rather than waiting it for some time. And Remember something why this is important, because whatever we do, there is something which is still going on as an IV fluid. So patients are getting antibiotics, patients sometimes are getting sedation, sometimes they are getting analgesia, they are getting some other drugs as part of their routine management, and many of these drugs are being diluted into a saline bag. So remember, most of the drug diluents are saline bags. So if you are using unjudicious use of maintenance fluid, thinking that I am replacing that, you are forgetting about something known as fluid creep, which is going on, and unfortunately you can't do much about it. So whenever you are calculating a maintenance fluid, aware about of this fluid creep. And sometime it's better to think on it, that whether I need to prescribe any IV fluid, because patient is already getting enough amount of these fluid in these diluents, and most of the time these are extra sodium, because most of the drugs are diluted in a saline solution. And that's the reason sometimes we don't need to prescribe anything for this patient if we try to count up this fluid creep, which is anyway going up to these patients. So really important is to start fluid stewardship, and that what is the whole message, to look at drug, dose, duration, and de-escalation. So I will not go much into detail about how to start, but yes, the important part is to look for this paper. I would recommend, if you want to think of a fluid stewardship, this was a very good paper, which was again freely available in the internet and could be a good resource to start off a fluid stewardship. But what is important is look at the problem, find out the right team, and look at what is happening at your bedside. Look at the key performance indicators. So that's a bigger topic, but yes, to tell you, we should think of fluid stewardship as part of our routine daily management, and that has been found to be successful in most of the situations. So to wrap it up, IV fluids are drugs, and we need to be very, very judicious for their rational use. And there is a time that we should consider a fluid stewardship. If you are considering one, I will highly recommend to join you for this course, which is a free course. It's a fluid championship course. Again, came out through International Fluid Academy, which I'm proud to be part of. So this Fluid Academy is an open access academy, which give you a lot of resources. You can search it for Google, and this is a very good QR code which you want to join as a Fluid Championship course. So it gives you a basic information all about what I tried to talk in last few minutes, and also will prepare you how you can implement fluid stewardship in your settings, whether you're working in A&E, ward, or in ICU. And this is the link for the book. If you have not downloaded the book, please feel free to download it. It's a good resource, updated resource, and it tells you how to use your IV fluids judiciously into your settings. Thank you.
Thank you so much, sir. Thank you for your overwhelming talk that you have shared with such a beautiful insight and PPT presentation that you have shared with us for our viewers to make them understand about the topic. Moving ahead with the question answers round that we have received, the first question is related to the osmolarity. So, how can the osmolarity and tonicity of fluids impact patient outcomes?
I think it's a very good question. So we have to remember the most important component which decides the osmolarity or so-called tonicity of a fluid is sodium. Uh, twice the sodium is the osmolarity. For a very simple example, let's take a saline bag which has sodium and chloride. As I said, the important component is the sodium, and it has sodium of 154. So twice that is 308. So the osmolarity for a saline bag is going to be 308, 154 multiplied 2, so that becomes 308. And to give you a context, we the normal osmolarity of human blood is between 275 to 285, and that tells you that a saline bag is hyperosmolar. So anything above this 285 is hyperosmolar, anything below 275 is hypoosmolar. And very similarly, let's take an example of another solution, which is ringer lactate, again a common solution. So the sodium content is around 130 in that. So twice of that becomes 260. So a ringer lactate is a hypotonic, while a saline bag is hypertonic or so-called hyperosmolar. So tonic is something which is out of the blood, and osmolarity we tend to use this something for our human body. So osmolar solutions. But in context of an IV fluid, we use hypertonic or hypotonic, which is in relation to the blood osmolarity. So osmolarity is twice the sodium. If we take that in context of blood osmolarity, if a solution has tonicity or rather osmolarity above the plasma osmolarity, it becomes hypertonic. If it is below, it becomes hypertonic.
Thank you so much, sir. Thank you for answering that question. Moving ahead with the other question that we have received from our viewer, and the question is related to the key indicators for initiating for fluid therapy, and when should oral hydration preferred over I5 hydration?
Oral hydration is always preferred over IV hydration. What are the key things you need to be aware about how to start an IV fluid? As I said, first is an indication why you need to start an IV fluid. So that should be there for every drug. So you should think IV fluid like a drug. The way we think, when the moment we start thinking it like a drug, then you should be always looking first whether we need to start an IV fluid. Yes, if we need to start for some reason, whether for resuscitation or maintenance, then what type of IV fluid, because it depends upon the indication. As I said, for resuscitation, it has to be a balanced crystalloid, while for a maintenance, it need to be hypertonic fluid, because anything which is isotonic will be extra sodium. Then once you have identified the type of the fluid, the second thing is the dose. So dose will be again varying with the indication why you are giving. Most important is once you have started, make sure that you're reaching your targets. Once your targets are achieved, try to make sure that you are stopping that particular drug. So you are stopping IV fluid for this patient. So do not leave that IV order to continue and leave your nurses to decide on it. As soon as you finish your target, it means in a patient, in a situation for maintenance fluid, if patient starts taking orally, make sure that you stop all IV fluid for this patient.
Thank you so much, sir. Thank you for answering that question. Moving ahead with the last question before we conclude, and the question is related to the potential risk and benefits using hypertonic saline in critically ill patients.
Okay, so benefit, I don't think I have a benefit. Yes, for resuscitation, if we need to give a fluid, that's a the best thing is we have very easily available ringer lactate, the way it is easily available like a saline bag. So of course, a saline solution should not be used for resuscitation. As I said, balanced crystalloid like a ringer or a sterophundin should be used. Uh, what are the only reasons why I still use a saline bag is, of course, a drug diluent, which are also something we question, that many of the drugs can be diluted in so-called hypertonic fluids if we start looking at the formulary. But the other could be indication if a patient has a nasogastric tube and he or she is having a lot of nasogastric aspirates. In that case, to replace those nasogastric fluid or a nasogastric aspirates, which are more of gastric aspirates, a saline bag is a good, because it's by default a acidic fluid, and that helps to replace that.
Thank you so much, sir. Thank you for answering that question and all the other questions for our viewers, and for making them understand about the topic in such a better manner, and for answering all the questions. So, thank you so much. Thank you for it, sir. And with this, we would like to thank all of our viewers for their ardent participation that they have shown by staying tuned throughout the session, putting across such interesting questions to us. So thank you, sir. Before we conclude, any last take home message from your end, sir?
Now, I think we should treat IV fluid as a drug, and if you start thinking it like a drug, then of course you will start following the other things. So they are like drugs; they should be treated like drugs.
Thank you so much, sir. Thank you. With this, we are concluding the session here for today. Until next time, and I would request our viewers to stay tuned for further episodes of our sessions. Thank you.
Thank you, Batul. Thanks for
Thank you,
having
sir.
me. Bye.